Good evening, Facebook Live, and welcome to two of my very favorite practitioners. One who has been with us the whole time, he's never missed an Endo Summit, and another who I think is just fabulous. Welcome from Texas, Dr. Rachael Haverland, and from California, but he used to be in New York, Dr. Laurence Orbuch. Dr. Rachael, you want to introduce yourself a little bit?
Yes, hello. Thanks for having me, Sally. I'm Dr. Rachael Haverland. I am in Dallas with Endometriosis Center of Excellence. This is my third Endo Summit.
Oh. How did
And
we
I'm
exist
happy to be
before
here.
you?
Yeah.
I feel
I
like
mean, I mean, I finished fellowship 6 years ago now, but that was COVID. Do you ever remember that? Nothing was really happening. It took a little bit of time, but yeah, I'm happy to be here. Thank you for having me.
we love having you. And Dr. Orbach, go ahead and tell us a little bit about yourself.
Hello, everyone. I'm Dr. Laurence Orbuch. I used to be in practice in New York. I've been in Los Angeles now for coming up on a decade. And I've known Sally for God knows how, probably 20 years.
Right. Probably
Um,
20 years.
and uh, and basically my practice is endometriosis and all the aspects of it.
Excellent. Okay, so you guys chose not the topic tonight, but you also wanted to be together, and because it's something uniquely that you're passionate about. Dr. Rachael, tell me a little bit about why talking about endometriosis and then all the other things that cause pain with endometriosis is so important to you.
Yeah. So first of all, I wanted to be with Larry because Larry and I get along quite well. And we did this 2 years
Yeah.
ago
Yeah.
as like a similar group. But the reason I think that it is so important to talk about the other like pain modalities associated with endometriosis, because endometriosis is very much of a whole body disease. It affects your body as a whole. It is not just a pelvic disease. It is not just a disease of the reproductive organs. And I think it's really important to discuss that with patients so they kind of understand why a multidisciplinary approach is so important. Why, when you have a multidisciplinary approach, you get better outcomes. And also understanding that since I'm an endometriosis surgeon, I feel very comfortable with like very wide excisions and thorough excisions, but surgery is not the end all be all. I talk about, in one of my webinars, like surgery is not the finish line. Surgery is the starting point to like getting rid of the underlying etiology, but understanding and talking about some of the other sequelae that can cause pain, whether it's in different organ systems or it's a central sensitization of pain. I think it's very important as far as endometriosis education goes. And sometimes I feel like it's left out a little bit. Because I'm a surgeon, I love to do surgery. I see a lot of benefit from surgery. Well, I obviously think it's the gold standard. I do think that there's some importance with discussing some of the other etiologies of pain and how they all kind of interconnect and affect the body as a whole.
Yeah.
Excellent.
Yeah. And
Dr.
just
Orbach.
Yeah, and just to kind of add to that, I think the if you understand the pathophysiology of endometriosis and how it impacts, just as Rachel mentioned, it's really a whole body phenomenon, and I'm the same. I mean, I'm a surgeon. I like to operate, and it's kind of the cornerstone of treatment. You can't get rid of the continued problem without getting rid of the source of all those symptoms. But I think that what's frequently overlooked or not even given any notice at all are all the coexisting pain generators and the manner in which the endometriosis over time really ramps up the entire central nervous system and activates other pain generators is something that's critical. And I see a lot of patients who may have had surgery elsewhere in the past, and they may have gotten better from the excision, but no one ever addressed the other issues. The pelvic floor dysfunction, the interstitial cystitis, the SIBO. The list is long and very complex. then you're kind of not you never achieve the best you can be, so to speak. So I think that in my practice, and I'm sure Rachel does the same thing, especially in patients who aren't having surgery right away, because everyone has, life gets in the way and they have schedules and they kind of want to time it in an appropriate time that's convenient and that gives them the opportunity to recover the way they want to. I always start treating these other pain generators in the interim, and it's a big boost to the individual because they start seeing improvement. So when you start seeing improvement, you kind of see the light at the end of the tunnel, and you're then committed to the whole game plan of how to approach treating this full body kind of phenomenon. And I think that's really critical.
Yeah, I agree. And down regulating some of that pain response before surgery, I feel like, at least in my patients, they have a better recovery, like they have a better outcome. And a lot of times they're already sort of, they can pick back up where they left off a little bit easier. Like, okay, I'm getting back into physical therapy or whatever next steps are. And I do think the recovery is a little bit easier if you can start down regulating ahead of time, which sometimes is hard. I mean, we're all so busy, you know, the patients, but when they really make that a priority, I feel like they get better outcomes.
Yeah, absolutely. And I think once it's compliance with a treatment plan is always challenging, especially when it's over a long period of time. But I think, like I said before, when individuals start seeing the benefits of what you're doing, and like what Rachel was saying, you're starting to downregulate the central nervous system overactivation, be it, with starting them on medications like gabapentin or Lyrica
Mhm.
or with suppositories, to decrease the inflammation and also give them some muscle relaxation.
Mhm.
Really
Mhm.
makes a huge difference. So, I always tell them, you're starting up here with pain. If
Yeah.
I can get you down here before surgery, you're going to be you're going to be more resilient in your recovery. So I think it really is quite effective, taking this approach.
Yeah, I agree. Do you use SSRIs much or SNRIs much, like as an initial approach, or do you
I
usually wait
I
on that?
I have. It really depends on how much is going on with the individual patient, and
Yeah.
if I think that hitting them with that right off the bat or early on is worthwhile. And a lot of people have been on different therapies that
Yeah.
haven't worked, So it's really kind of it's not and correct me if you disagree, but it's not a cookie cutter approach. Everyone needs
No.
a different combination of treatments. And you have to tailor it to the individual and
Yeah.
also tailor it so it doesn't overwhelm them. You don't want to start them on too many medications with which many have side effects, especially in the beginning,
Yep.
which discourages them. Then they'll call you, they'll come back for their follow-up. They're like, well, yeah, I tried the medication, but I didn't like it, so I
I
stopped it.
was so groggy I couldn't do this, or
Right. Like,
yeah, I
yeah,
agree.
yeah. And it's like, how
Okay.
long were you on it? Like, I was on it for a week, that kind
Yeah.
of thing.
All right, let's back up a little here. What is central sensitization and how does that affect the endometriosis patient? You want to divide that in two?
Sure.
Sure.
All
Go
right,
ahead.
Dr. Haverland, you go first.
Okay.
Okay. So I'll start with what is central sensitization of pain. So I like to explain it is your body gets used to feeling pain. When you have this inflammation from endometriosis or really any other chronic disease, your body starts getting used to pain. You have nerve receptors that are used to firing. Your brain is used to receiving these pain receptors, and your body is used to being in pain. And so the central sensitization of pain sometimes changes your the amount of inflammation or the amount of stimulus that causes a similar reaction. And so women that have, or any patient that has this central sensitization of pain, it may be something as mild as ovulation, for example. Ovulation certainly can be painful, something called middle spurts, but women that have this central sensitization of pain, something as simple as ovulation every month really can just throw them for a loop because their body is already at this heightened sensitivity for pain. And so it really doesn't take much to just sort of push them over the edge. And so it's important to understand sort of where their neurologic system is as far as the central sensitization and try to downregulate it the best you can, start to change some of the brain's understanding of the perception of pain. And we always talk about how endometriosis is very not much, it's not a mental, it's mental disease. It is not in your head. It is in your pelvis. I actually have a shirt that says that, but it's very difficult for it not to affect your mental health because you're in pain so frequently. And so it's important to at least understand those properties and have a discussion about the different options. And sometimes those do include SNRIs or SSRIs, which sometimes are used for depression or anxiety, but they also can be used in the right patient for the central sensitization of pain to start sort of helping with this rewiring of this cyclical inflammation that your body is used to receiving.
Yeah, and it's the way I like to explain it to patients is it's a threshold thing. So
Yes.
if a normal person has a pain threshold that gets triggered here, your pain threshold is down here. So it doesn't take a lot to push, like you said, push you over the edge. And it also it ends up for a lot of patients lowering their threshold for any sort of sensory input. So like I have a lot of patients who I'll guess it in advance, just talking to them and even looking at the way they dress, that they can't stand tight clothing or they can never
Mhm.
wear jeans because
Yep.
they feel uncomfortable and it's like they can't even describe the discomfort that they feel. It's not sometimes it's not a lot of the issues are not pain per se. It's just
Mhm.
this perception. It's just this intolerance for things. And it's sort of like the other way that I explain it to people to kind of give them a more lay approach to as an analogy is it's like having it's like if you listen to your stereo and you have it on on number five level of volume, it's pleasant, it's music, and you're enjoying
Mhm.
it. But if I blast it all the way up to 10, or they said in Spinal Tap, up to 11, you know, it's 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 noise and it's
Yeah.
overwhelming. And even though it's with pain, it's not like an audible thing, but your brain is getting these constant pain signals, just you know full time. And that's why I always tell patients, I'm like, let me guess, you have brain fog, forgetfulness. They're like, yeah, how do you know that? I'm like,
Mhm.
because you're dealing with so much input that
Yep.
your central nervous system and your brain cannot handle it, and you're just
Yep.
overloaded.
Yeah, that's a great way to explain it. I might steal that from you.
Okay.
I also like the fatigue. I think the fatigue is also
Yeah.
it's a part to some degree of that central sensitization of pain because you have very little left in the tank because you're just so
Yeah.
overstimulated all the
Yeah.
time.
Yeah. And then they have sleep issues and insomnia and mood disorders. It alters your general sensorium.
Mhm.
Excellent. Well, we like to talk about like that in the PT we say it central sensitization is about the brain recognizing that the volume is turned all the way up, and then even after we remove the endometriosis lesion, no one's turned the volume down yet.
Right.
So you talked a little bit about SSRIs. What else, Dr. Orbuch, are you doing to what I call down regulate the central nervous system?
So like I said, there other oral medications that are commonly used are things like gabapentin and Lyrica, which kind of start to lower the pain threshold and kind of calm the nerves down. And then from a PT standpoint, what I think works really well are these compounded suppositories that can be used vaginally and rectally with medications like baclofen and Valium, to simultaneously help bring down inflammation and also relax muscles. And I always tell patients that that the suppositories in conjunction with the PT, it's not additive, it's exponential. It's like one plus one
Hmm.
equals four because
Yeah.
the PT works much better when you're bringing down a lot of the inflammation and relaxing the muscles, locally in the pelvic floor. So those are some of the things. The other things that I find that work well for patients are, things such as acupuncture, I think really works
Hmm.
well. And doing a lot of like stretching where you're kind of adding to the PT by like doing lengthening and stretching
Hmm.
muscles.
Yeah.
It's just everything to kind of just calm your body down, decrease the inflammation, and also really cool off your central nervous system.
Yeah.
Now we used
I
to, sorry, go
go
ahead.
ahead. I was saying I have added acupuncture as well in my kind of recommendations. But the last thing is I do ask them to at least think about their diet. Now, not diet does not make the endo go away, but there are triggers. And, we know that women with endometriosis tend to have more food sensitivities than others, just because when you have this chronic inflammatory disease, your body may not process foods the same way as somebody without a chronic, inflammatory disease. Gluten is a big one. Not everybody has a gluten sensitivity, but just thinking about what you're putting in, because some foods tend to be more inflammatory than others, and it's not a
Yeah.
one size fits all. But I do at least have them rather talk to a dietitian, or try to work on kind of clean eating, or just think about some of the foods that they eat that may be triggering to some of the inflammation, rather it's bloating or more nerve pain. Diet is hard because you don't see an immediate benefit. You don't eat good one day and see the benefit the next day. But I do think it's important, kind of as the
Yeah. No, and
plan.
I do the same. I start off at least, because you give them a lot of homework and it's really overwhelming. But one of
It
the
is, it is.
when it comes to diet is that, I tell them, try to have a low preservative, more organic diet,
Hmm.
because all the for lack of a better term, crap that's in a lot of the things that you buy, at the store, if you're not careful, you're really subjecting yourself to a lot of pro-inflammatory things in your environment, and it goes beyond diet as well. I mean, I usually tell them to like download the environmental working group uh, app on their phone, the EWG, which rates products, and it rates on a
Hmm.
scale of 0 to 10. 0 is the best, 10 is the worst, and people are shocked sometimes when they see what's out there. This is all FDA approved, um, but it's like really not healthy. And when
Yeah.
you're that sensitive to inflammatory triggers, you're the prime candidate to be set off by a lot of these things. So it's diet, it's all the products in your environment, like cleaning products, soap, detergents, shampoo, conditioners, makeup, lipstick. I mean, the thing I always tell people is that, before you leave the house in the morning, you're exposing your largest organ to like so much stuff, meaning your skin. So you
Yeah.
get up, you brush your teeth, you wash your face, you take a shower, you use shampoo, conditioner, moisturizer, makeup, lipstick, eyeliner. Think about how much you've thrown at yourself already, and then add to that your diet.
Yeah.
And I have patients who have all kinds of skin issues like eczema and sensitivities and stuff.
Hmm.
And they'll I tell them like go gangbusters on this. And like within a month, they're like, oh my God, my skin hasn't felt like this since I was 20. Uh,
Yeah.
so it
Yeah.
could make a big difference. And it's all these elements, eliminating them from your world, so to speak,
Hmm.
can really help, and and I think the point we're trying to make overall is just it's a cumulative phenomenon.
Yeah.
And like Sally was saying, there's no one thing that's going to be the magic bullet because there is no magic bullet. It's a process, and to reverse a chronic process that's for many people has been going on for years, if not decades, it's not going to happen overnight. So, good surgery and then good adjunctive therapies
Yeah.
is really critical.
Yeah.
You each would have loved Dr. Vidali's presentation last week which was really on the cellular matrix of what is making up that inflammation in
Hmm.
the body, and why even when we remove the lesion, the damage to the mast cell system still exists, and the body is still producing inflammation even after the lesion is gone. Which, by
Yeah.
the way, even 5 years ago, we didn't have conversations, and here you guys are talking about it again. This is a very important
Yeah.
component to
Yeah. Well,
endometriosis.
and so important to talk about up front. You like never want a patient to have surgery and still have pain and feel like they're a failure. But talking to them about expectations and next steps, I think up front is really helpful for understanding expectations after surgery, knowing that if your pain is not resolved, at 4, 6, 8 weeks, that's actually very common. You just have to work towards next steps, and that you have a plan already set in place that you can start to implement it, if you haven't already done so before surgery. But it's just some of endometriosis is also like this mental game of not giving up because you've been through so much for so long and you finally feel like you have hope. And so just talking and setting expectations and helping them the patients understand this
Yeah.
multidisciplinary approach, I think is paramount for overall endo treatment. And I think that's what we're getting better as a group of endometriosis specialists is understanding this, holistic approach to endo rather than just focusing on surgery alone, which again, I think is paramount, but it's not the finish line.
Yeah, no, I totally agree. And I think, the every week I have patients telling me like, and they've usually seen many different physicians and they're like, it's like a light bulb goes off in their head because when you actually take the time to explain what they've been experiencing and why they've been experiencing
Yeah.
it, because for most people, you have symptom X, Y, Z, J, K, L, M, N, O, P, and they're all over the place, and they've been to like 10 different doctors treating symptoms. They don't see the linkage between all these things. And when you start explaining the pathophysiology, and I'm a big on pathophysiology, it really it helps them understand it. And then when they understand it and it makes sense, then the plan you give them and the solutions that you're offering, are logical. And then you have what I always refer to. I always tell patients, I may be overloading you with information, but I want an active participant. I don't want a passive passenger along the way, like, listening to me say, do X, Y, and Z, and they do it and they don't understand why. So I think
Yeah.
that's how you get long-term commitment to a plan. And I think that's what Rachel was driving at, is by really informing and educating.
Yeah.
I also believe, Dr. Orbuch, that this population, our community, the endometriosis community, is practically abused by the rest of the world. And doctors sitting there and explaining and trying to get an active participant and playing a role in educating them, but asking them to also play a role in educating you. That's how we rebuild trust because
Oh,
you
absolutely.
and it is like when you're so broken and from the gaslighting, that is such an amazing step when the doctor takes that time to be a team member instead of just feeding a solution that may or may not work. Like, I hate that. I hate when the fertility
Yeah.
patients call me and they're like, oh, they just said if I do this, then I'll get pregnant. It doesn't work
Right.
that way.
Yeah.
Doesn't, yeah.
You know,
Uh, yeah. I have a question. Are any of you, either of you, starting to work a little bit with vagal nerve stimulators to modulate the central nervous system?
I have a few patients that have done this, but I haven't done it personally. So I have two patients and their experiences from this. But no, I maybe we'll talk about it more at Endo Summit.
We definitely will talk about it more at Endo Summit, but the PT likes to modulate it through exercise and movement. So I'm
Okay.
just curious if you're using the stimulators yet.
yeah, I have not either.
Yeah.
Are they implanted at surgery or do they implant
No,
it
they're
separately?
they're like independent, really.
Okay. Is it
Yeah.
something like a belt that you wear, or is it like
Yeah, a little bit
implanted?
the ones that I've seen a little bit similar. We'll have to ask Dr. Davis. It does a lot of work with vagal nerve, Ashley Davis.
Uh-huh.
A lot of
Yeah,
Hmm.
work with vagal nerve stimulators, but also part of accessing that neuroimmune system is
sure.
using these vagal nerve stimulators.
Are they
And
similar to a TENS unit and like
yeah,
how they're implementing?
little bit. I have not seen them. I have not seen any implanted. I don't know. No.
Okay.
But I will say Ann Duke did the lecture last year. It was concurrent, so you might have been in another session about exercises for the vagal nerve system, and we got all sorts of crazy comments. So first of all, I did it and got a sinus infection and was so dizzy I couldn't leave the house because I watched the recording and I missed a tournament. Ann's in trouble because I missed a tournament. But other people like had a lot of their, the POTS symptoms during the surgery. They have to tip the table, but there's no way to do the surgery without tipping the table
Right.
back. And a lot of people get a POTS flare. I had people writing like crazy that it helped their POTS flares, the
Mhm.
movement, so much so we're going to give a whole other session in her doing exercises again.
Great. I love that. Endometriosis is so common with POTS as a concomitant, disease. I do talk to my patients about trying to similarly downregulate with some exercises for POTS in anticipation of surgery because it is so common to get a flare. And my anesthesiologists are great because so many of my patients have POTS. They're very used to taking care of patients with these comorbidities. But I think that'd be great to give them, some actual like I usually tell them, talk to your physical therapist, talk to them about what exercises you can do. But if I could actually give them some exercises to do, in addition, I think that that would be huge.
Yeah, we'll have to ask Anne at the summit.
Hmm.
Yeah.
So, let's talk a little bit about systems, even though I believe what the two of you are talking about are whole body. How does that, the bladder drive pain that people often mistake as having more endometriosis?
So yeah, so the common condition that we see a lot is interstitial cystitis, and just to kind of give a little bit of an explanation for people who are not familiar with it, it's an inflammation in the bladder wall. So the interstitium is the layers of the bladder wall that's under the surface, the epithelium that lines the bladder. And what happens is there's a protein coat that protects that inner lining inside your bladder from any irritants in your urine penetrating into the bladder wall and causing irritation and inflammation. And something triggers that the kind of cracks or breaks in that lining, which allow substances that are irritating, like that are acidic or high in potassium, to
Mhm.
penetrate. They then trigger nerve endings, which trigger an inflammatory response, which then degranulates mast cells, which have histamine in them in the bladder, to then release the histamine, and the histamine then causes even more profound inflammation, and then it's just this vicious cycle. And it it can mimic a lot of the endometriosis like symptoms. It can also mimic urinary tract infection symptoms. So many patients will, when you probe them in their history, they'll tell you, they have like many, many UTIs, and like three, four, five, six times a year. And, they call their primary care doctor and they just knee jerk give them some Macrobid or Cipro. And, and like, does it ever help? Well, yeah, usually within a few weeks, I feel better. I'm like, well, if it
Yeah.
took a few weeks, it wasn't an infection. So yeah, on occasion they may get an infection anyway. And it's part of this whole inflammatory cycle that we see
Mhm.
with endometriosis patients. And you, and I've had my share of patients in the past where, they didn't buy into the whole interstitial cystitis diagnosis until they had surgery, they had PT, they had everything else, but they still come back with the bladder symptoms. And I'm like,
Mhm.
well, it's time to address the bladder symptoms. Like, oh, really? It can't be. I think it's my endo's back, and no,
Yeah.
let's treat the interstitial cystitis, and I'll see you back in 6 weeks. And
Yeah.
sure enough, the overwhelming majority of the time, like, oh my God, it's like someone turned the light switch off. Um,
Yeah.
so
Yeah.
that's ostensibly what the bladder issues are.
Yeah, I agree with that. I always do a cystoscopy for my patients, but you can have interstitial cystitis without the, kind of classic
Yeah,
Hunter's lesions that you see on
yeah,
cystoscopy. And sometimes I always explain endometriosis doesn't have to be on the bladder for it to be affecting the bladder. Because they'll go in
right.
and be like, hey, doc, how did my bladder look? Well, your bladder looked fine, but you had, stage 3 endometriosis everywhere else throughout the pelvis. And just explaining the anatomy of how these organs live so close to each other, how any inflammation, near them, they kind of bathe in a similar fluid, can affect the bladder. Rather, urgency, frequency, pain when the bladder is full, the frequent UTIs with a negative culture. Those are kind of the things that I'm also looking for. And I would say at least a third of my patients probably have like a true interstitial cystitis diagnosis.
Yeah, I do the same. I do cystoscopy on every patient because you don't want to leave any stone unturned
Right.
because if it's there and you don't know it. And also, I also agree that it doesn't, if you ask a urologist, they'll tell you unless you see the classic findings, you can't make the diagnosis. But you frequently see, you may not see Uner's ulcers or you may not see glomerulations, but you may see a very red, angry looking bladder epithelium, which is not normal. It should, and you'll see areas that are normal, kind of pink, and then these other areas that are red because you can see the prominent vasculature at the surface. The blood vessels are like big and plump. And there's no, the treatments are so benign that it's a no-brainer, to address it.
It's interesting because the big guy randomly is texting Maurice Chung, and now we realize we're online and he's texting
Oh,
all these other questions. But I think what is really important to realize about the bladder is the main sensory driver of the pelvis. It is the organ that's sort of like the sensory command
it's
center.
the conductor.
Right. It's the conductor, and it goes into nerves S2, 3, and 4, and so does almost the rest of the pelvis. I mean, I could draw it out for you. We don't have to prove how smart I am. But the reality is that once that signal, just like Dr. Haverland was talking about, once that signal has taken over your pelvis, you can have endometriosis nowhere near your bladder and still be aggravating those nerves so much they're driving a crazy amount of bladder related pain. Yes, that's my soapbox.
That's very true.
Yeah.
Yeah, and the other thing is, and this is one of the things I explain to patients when they try to kind of wrap their head around where all these different symptoms from both sides of their pelvis and their abdomen, like where they're coming from, and I explain to them the nerves are like tentacles, and they come off you, the nerve roots come off the spine, and then they just keep branching, and that's any signal that hits any of those nerve endings has got to backtrack its way through that web of nerve endings back to your nerve roots to the spinal cord and then up to your brain. And this is part of the whole central sensitization concept. We're not wired, it's like there's a lot of redundancy in the way that our central nervous system is wired. So there's a lot of cross communication between nerves. And that's why, when you probe these patients, with about their history, they'll tell you, I started out with very pinpoint one-sided pelvic pain that suddenly became bilateral pelvic pain that became suprapubic pain, then pain radiating to my back, and then shooting pains down my legs and tingling on my toes and numbness when I would sleep on my left side, and it just goes on and
Yeah.
on and on. And that's how you get this kind of this amplification or this blossoming of symptoms. And to what Sally was saying is these nerve roots that innervate the pelvis come from these main nerve roots that innervate everything in the pelvis. So of course you're going to have this connection. And I always tell people, patients will always not always, but frequently will say, I know you're going to find everything right here on this side. And then
Yeah.
you do the surgery, you're like, yeah, you had a lot of stuff, but it was actually on the other side. So, I
Yep.
explain to them the concept of referred pain. So like what you think, is not necessarily where, where the issue is. And like Rachel also said that, you may have tons of bladder symptoms and you have no disease on the outside of your bladder. You just have
Right.
all the inflammation on the inside of your bladder.
Yep. Yeah. And anticipating that and talking to them about it again ahead of time, but also talk to them about, hey, even if we go in and we do the cystoscopy and we don't see the true pathology with the
Right.
Hunter's lesions, it does not rule it out. Just like imaging does not rule out endometriosis, a cystoscopy technically does not rule out interstitial cystitis. A lot of these diagnoses and these treatment plans are based on symptoms, and that's why it's just so important to listen and get a thorough history, but also just the underlying understanding and being able to navigate these different symptoms. When patients, I think, see a true endometriosis specialist, somebody that sort of understands this holistic approach, it just, like you said with your other patients, like, hey, I have the fatigue, I have the grogginess, I have the fog. How do you know that? Like, how do you know that this is this is what I'm experiencing all the time? But you can almost anticipate, sort of based on what they're explaining to you, what some of their additional symptoms would be.
So what is your bladder approach?
For me,
Aside from looking during surgery, patient comes in, you see
Yeah.
that by the way, as a PT for all these years, I've seen Hunter's lesions maybe twice. And
Right.
so
Yeah.
what is your approach, Dr.
I
Orbuch?
I generally, from their history, if there's a lot of bladder symptoms, what I usually will do is I give them a copy of the IC diet guide, the interstitial cystitis diet guide, and which is I give them a nice 20-page little diet guide, which gives them the basics and also the link to their website, so they can start an elimination diet. And I always tell them, like, you can't eliminate everything. Some things because some patients will tell you, like, if I have a glass of red wine with dinner, I'm up 3 or 4 times in the middle of the night peeing and I have this severe bladder pain. So that that's something you need to avoid or minimize, unless you're willing to pay the price. So I'll have them do an elimination diet, eliminating a bunch of big ticket items. I tell them to do it for like 6 weeks and see how they're feeling. And then each week thereafter, you add back one thing. This way you
mm,
can tell if that's a trigger. Um, in addition to that, a very benign treatment is using Atarax, the hydroxyzine, which is a strong antihistamine at bedtime, because that stabilizes the mast cells, and you get less of this chronic inflammatory cycle that's been going on, and it gives your bladder a chance to heal. And the way I explain it to patients, so that it's more. It's something that they can relate to is like when you talk about mast cells, I'm like, if you have seasonal allergies and you get red, itchy eyes and your nose is running and your whole face feels like it's burning, I go, that's what's going on in your bladder. So if we can stop that, then, you can reverse it. In more extreme cases, if they need bladder infusions with
mm,
that's a little more advanced. But as a starting point, putting them on a low sodium, a low potassium, low acid diet, um, starting them on some antihistamine at bedtime, which also
mhm.
helps them sleep because a
Yep.
lot of times when I tell them the urgency feeling is because your bladder, the inflammation is in the wall of the bladder and it's irritating the detrusor muscle, which is the muscle in your bladder wall, which contracts when you bear down to void. That that muscle is being irritated and stimulated by inflammation, and it causes it to spasm or contract, and that's what makes you feel like you got to go. So
Yeah.
if you're getting better and you have a little spasm in the middle of the night because of the antihistamine making you sleep well, you probably won't wake up from a lot of those. So
Yeah.
it starts treating the problem, but it also helps with their sleep cycle, so they're not exhausted all the time.
Yeah.
You're chopping away, piece by piece at all these different issues that are disrupting their normal, life.
Yeah. I like Atarax. If Atarax in addition to the diets aren't seeing benefits, sometimes I use like a small dose of Flexeril too at night, just because it helps with some of those bladder spasms. And
Yeah.
usually it doesn't give you as much like fog the next day, like
Hmm.
some of like the Valium or the big hitter muscle relaxers does. But that's my next step, outside of like the bladder infusions and things like that.
So how much of the like RNA testing are you doing for the bladder, if at all? You're all gonna say that. So I sit on this patient advocacy board or whatever with the AUA, and the IC people are there. And even though I had read the research on things like microgen before, it wasn't until I talked to their side of, they also have their patient groups and their advocacy groups. And their groups were saying they pick up all sorts of things that are part of what's making that bladder red, and sometimes like giving those little cracks that lets the redness infiltrate the lining. So I started to sort of advocate for that. Dr. Vidali probably wants to kill me because every patient is, do you want me to have that test? But I also feel like it's a test that for the most part is covered. Like, why not try it?
Yeah. Yeah. I mean, knowledge is power. The more information you have, the better. And sometimes if all other options have been exhausted, eh, you know, I think it's reasonable and it's minimally invasive with a blood test.
Yeah. Yeah.
Yeah, I just have to read up more on it. I honestly don't know a lot about it.
Now, post excision, people come back urgency, frequency, maybe like a year later, and they're like 36 and up, or even younger. It doesn't matter. Are you starting to use vaginal estrogen for some of the bladder symptoms? I
I
don't
think
want to
that,
take the lid off the whole conversation,
Mhm.
just related to the bladder.
yeah. I think vaginal estrogen can be very, very helpful, especially for women that are kind of starting that perimenopausal area, just to improve some of the tissue integrity of the vagina, which also helps the urethra. We know that it helps decrease, it can improve stress incontinence. It can improve, dyspareunia, but a lot of the bladder symptoms as well. So I'm a huge proponent. And I still see, even though we're ovary savers in this group, I still have patients come to me all the time that have been, castrated or had their ovaries out. And a lot of times they're not being adequately managed with their hormones. They need more estrogen than they were given previously.
Yeah, I use it as well, and also it's more prevalent in the perimenopausal age group, or the ones that have lost their ovaries already.
Mhm.
I think it's very valuable, and it's not a long-term treatment. It's a finite for a finite period.
It can be a long-term treatment, by the way,
It
because
can.
if you look at the other things that it provides, which we're not going to do tonight, because then I'll get a million questions on that. We have a question that's talking about like urgency and frequency. I happen to know the person, and I feel like saying like that might be in the absence of bladder pain. That might be a good time to talk to your doctor about the vaginal estrogen. Yeah. In my experience, it also helps with that patients who have that detrusor spasming you were talking
Mhm.
about before.
Yeah, I mean, because when you can't attribute everything to one problem. People can have endometriosis and they can have pelvic floor dysfunction, but they can also have detrusor instability or stress incontinence, and so forth. So you have to have a more of a kind of broad scope of what you're looking at. And I
Yeah.
think for us, because we kind of take a lot of things into account, we tend to take two steps back and look at the big picture. So and as gynecologists by training, we're that's the way we were taught to think, as opposed to being very focused, like a dermatologist. You come in, you show them the thing on your skin, that's all
Mhm.
they're looking at. You could have like a nail sticking out of your head and they wouldn't even address it. So yeah, I mean, it
Yeah.
really, you got to take all factors into account.
Do you want to
Yeah.
hear something funny? My dermatologist is this young guy, and I don't know if it's a girlfriend or a wife, has really bad endometriosis. And he's fascinated. Every time I come in, he's got to ask me another question. He has to know everything on earth there is to know about abdominal wall endo. And I'm like, would you like my card? Would you? Yes. So he's like the one dermatologist who I think is looking for more than,
Maybe he's educated in endo.
yeah, I just think
Yeah.
it's
Thanks to
funny.
you, Sally.
Yeah. So, aside from the bladder, what else are you seeing as an ongoing driver of pain that that makes someone go, nope, the endo's back?
Yeah. So we know that the number one non-GYN complaint that patients with endometriosis have are gastrointestinal problems. And they can, there are many possibilities, but it's again usually driven by inflammation. And the reason why you have frequently have the triad of endometriosis, bladder symptoms, and bowel symptoms is that they all have receptors for the same inflammatory mediators that are released from all the inflammatory conditions that are related to all three organ systems. So they usually go hand in hand. And when the endo flares, then the bowel symptoms, patients will tell you, like, when my endo flares, I get the pelvic pain, I get, cramps, and then I look like I'm 5 months pregnant because
Yeah.
usually there's so much
The bloating.
inflammation. Yeah, and the bloating, and they frequently have, small intestinal bacterial overgrowth. So it's it's this vicious cycle that keeps
Yeah.
following the same pattern. So you want to break the cycle, and things like SIBO are,
Hmm.
it's easy to test. Uh, and it's a lactulose breath test. It's a take-home kit the patients take home and they blow into these tubes and drink this stuff, and then you have an answer. But the thing to keep in mind is that the treatment for it is so innocuous and benign, that even when you have, if you don't have the test or you have an equivocal result, I generally treat them anyway because there's really no downside. And I would say at least half the patients I see with a lifelong history of these GI symptoms have been tested and have had SIBO multiple times.
Yeah.
Um, and and the thing that you have to remind them is it's not a one and done kind of thing. If you had SIBO, you're far more likely to have it again than someone who's never had SIBO. So
Yeah.
it's not, before you jump, and the thing I always tell patients, just to kind of go off on a tangent, is before you jump to the conclusion that your endo's back, treat the obvious other
Yeah.
causes that are there. Like the patients who call you 6 months after surgery where you did like this thorough excision and you looked at every square millimeter, and like, that there's no way that something, I mean, anything's possible, but it's highly
Much
unlikely.
less likely.
Yeah,
Yeah.
you really want to go back and treat things. And a lot of times you uncover that, patients will oftentimes, like, they feel so much better after the surgery that they never went for the SIBO testing, or
Hmm.
they kind of gave up on the IC diet and or any of the other things because they were feeling so much better, and then they backslide. And it's the
Yeah.
same thing with PT, and I'm sure you see this all the time.
Oh, yeah.
People will say, I'm having those twinges and the tightness, whatever. I think my endo's back. I'm like, no, you're just, you hit a bump in the road. You need to go back for some PT. It's not going to be like forever, but you need to go back for a couple of weeks, a couple of months to kind of smooth things out.
Yeah.
So that, my philosophy is never hit the panic button. Always, when you treat the obvious things. Where you hear hoofbeats, you think horses, not zebras.
Yeah. Yeah, I agree with you. One of the biggest things I see on the bowels, one is pain with bowel movements, which is pretty common, but chronic constipation.
Yeah.
And sorry, excuse me, explaining to patients that chronic constipation does not necessarily always resolve after endo excision and sort of talking to them about expectations there and some of the damage with the motility.
It's true. I mean, because a lot of these patients, I'll send them to GI and they'll do a workup and they'll do motility studies and they'll do defecography and even in young patients, they've had they may be in their 20s, but this has been going on since they were like 10. They have this whole dysfunctional motility pattern and also defecatory habits, and
Right.
and and you find You find that even when you go to do the surgery, you see that what's happened to their sigmoid colon. You have these big redundant loops of sigmoid that just act as like little outpouchings that slow down the transit out of the colon. So, and that's why they get constipated all the time. The
Yep.
stool just gets impacted in there,
Yeah.
and it takes a lot to get it moving.
Yeah. I think there's also some damage to the nerves, especially
Oh,
when
yeah,
patients have had, years and years of endo,
sure.
and it doesn't necessarily have to, but I think it affects the motility too.
Yeah.
Um, and talk to them about options. I like magnesium citrate at night, but talk to them like this may be long term, and it's okay. Like this is a
Right.
natural supplement. There's other options, but just because you feel better and some of your symptoms are recurring, it doesn't mean your endo is back. And kind of expectations, like setting those expectations and going back to the basics. Do you remember what we talked about at our first visit? Like, let's go through kind of what was affecting you before, what's better, maybe what's not better. What did you start and stop? Or maybe what have you continued? Or, what's changed? Like, has your diet changed? Did you start a new job? Did you stop doing your physical therapy? So, one of the questions in the chat was what resolves GI symptoms? In my mind, one is a good excision, especially like evaluating the rectum, but physical therapy, physical therapy, and
Yeah.
regulating your bowel movements, like having a daily soft bowel movement. But I think physical therapy is like paramount when it comes to like rectal pain or GI symptoms. Vaginal suppositories, I do think those can be helpful, or rectal, however you want to take them.
Okay, just a few questions. A lot of questions violating the Endo Summit rule, which is, we ask about theory. We don't ask about individual cases. But
Oh, okay. Sorry.
nope,
I may have
that,
answered one of those questions.
that's okay. You stayed within theory. So, Dr. Orbuch, do you see a connection between fibromyalgia and endometriosis? And is there ever a misdiagnosis?
So along the lines of what we were talking about before about coexisting other maladies, especially like ones of autoimmune origin. I do see a lot of patients that have endo that have some component of fibromyalgia. There's a lot of patients who have autoimmune thyroid conditions. There's a lot of Ehlers-Danlos patients. It's a it's a because of that, the conventional thinking has shifted to an autoimmune model. And I think you have to tease out the symptoms and treat things individually. So I think they're not mutually exclusive. So I think that you have to identify them and not ignore them, and address both.
Yeah. I see a lot of mast cell deactivation, POTS, Ehlers-Danlos. Those are my most common. It used to be fibromyalgia. Actually, I'm not seeing a ton of fibromyalgia patients. I think we're learning more that that's actually EDS, like hypermobile.
Yeah, yeah, and it was like kind of honing down on a component of another condition.
Right. Right.
I wonder, although we don't have a full, maybe next year this could be your webinar. Let's talk about teens and endometriosis for just a moment. I think a lot of teens present with the symptoms that aren't cramps,
Right.
Mhm.
that are
Yeah.
all these things that you're talking
Yeah.
about.
Especially GI symptoms like the nausea. Yeah.
Yeah. No, I find with a lot of my younger patients, when you start digging into their pediatric history, they had a lot of stomach aches, missing school because of it, and then all of a sudden, they went through puberty, and then all the period related symptoms began, and then it just continued. The classic story is that plus, then their mother's gynecologist started them on birth control pill when they were 12, and now they're 28 and they've been on it ever since. And now they've gone off the pill because they're trying to get pregnant, and they're like miserable because the
Yeah.
pill was actually suppressing some of the symptoms. And I'm a huge proponent of early intervention. And I have a whole cadre of patients who the mother was my patient. And then because they were kind of sensitized to everything about endometriosis, and
Mhm.
also me talking to them about the genetic component and the early
Hmm.
signs, and
Increased risk. Yeah.
right, and the increased risk of it, and they end up bringing their daughters to me when they're 14, 15, 16, rather than waiting until they're 30 or 40. And as we know from the literature, yeah, a lot of times the younger patients will have earlier stage disease, but we find advanced stage disease in young patients too. I did two cases last 2 weeks ago on one patient was 18, the other one was 24. It's shocking when you put the scope in and you see it. It was stage 4
Yeah.
disease in a young patient. And so you can't, the putting it off till you're older or putting it off until
Yeah.
you want to get pregnant makes no sense. It's like, when people tell me that, they've been told that by other doctors, I'm like, if you knew you had some chronic condition, would you wait until it was like a more advanced stage, or would you treat
Yeah.
it when it's earlier and it's easier to treat?
Yeah.
It just makes no sense, and I think that's part and parcel of the lack of understanding of endometriosis unfortunately, by a lot of clinicians, or the complete dismissal of it as an entity altogether.
Yeah, I hear that a lot. I've even heard patients tell me that, well, my doctor told me I was too young to have endometriosis, or,
Right.
well, I'm going to wait until I get pregnant. But, endo just grows. I say endometriosis says two things. It rather stays the same or grows with time, but it
Right.
is not going to regress.
Exactly.
And so it's never going to be a better time than it is now. And you can reverse some of the sequela when you've had symptoms for 5 years instead of 25 years. I feel like it's easier to reverse some of the damage that's been done rather than when you've had it for decades. And especially fertility, for my patients that want to preserve that, the earlier the better, because if we can treat stage 1 or stage 2 disease, your risk of recurrence is so much lower,
Right.
than if we're getting it with an endometrioma, for example, or stage 4 disease. Your risk is higher, there's more damage. Your fertility options may be more limited because the inflammatory effects not only on the tubes but on the ovaries and like the long-term preservation of that. So I'm
a
with
whole
you.
other a whole other webinar, but one of
Yes.
the
Oh
issues
yeah.
with care, I believe, abroad is that they do sort of hold to, if you're not trying to get pregnant, then you can't have surgery. And then that's so frustrating because if you went in before it was so extensive, you might have a lot better outcome. And both of you treat teens, so
Yeah.
I wanted to ask these questions.
Yeah.
Yeah, I think it's really it's a travesty that it's not looked upon as really a first line um, approach, to
Yeah.
be just as aggressive, whether someone's 18, 28, 38, doesn't make a difference.
Yeah. There's actually an ACOG bulletin or ACOG paper that came out that was kind of poo-pooing teens with
Right.
endometriosis. And, I did a self-preservation course a few years ago, and as like set your goals, like what is your goals for your future. And one of them that I set was trying to treat women earlier. The earlier, I mean, this was in my like career goals, but also like in my personal goals. Like the more we can advocate for women to understand this, the earlier women can get treated, the
Right.
better their long-term outcome, the less sequela they have to deal with going forward. And just it doesn't matter how young. If you have symptoms, just come talk to somebody. Doesn't mean you have to do anything about it, but at least like get some education about endometriosis. And then when you have that extra knowledge, then you can decide what's best for you. And I understand, surgery is intimidating, but there are other options outside of surgery. But surgery is important because sometimes frequently it's the only way to know because our imaging is lacking, and especially in young women, almost always it is normal, and we know what they're experiencing is not
Right.
normal.
Absolutely.
Yeah. When you do your teen webinar, which now
Yeah.
I have to have happen, We'll also talk about how there are so many just hanging a sign up that says we do excision because that's a good way to market to mothers of teens who are making the decisions. But the reality is it has to be a very clean excision with teens,
Yeah.
isn't it?
Yeah, I've
Yeah.
seen an excision and they take out a little dime-sized piece in the pelvis and like, well, we excised. And I'm like,
Yeah.
well,
Yeah, and the other thing, and again, like you said, Sally, this is for an entire other webinar. In teens, you really, it can, yeah, it can look like it does in adults, but
more atypical. Yeah.
yeah, many times it's much more subtle. And if you don't know what you're looking at, like I had a patient from London who I did surgery on, who had surgery in London, and they told her that she had, she really had minimal disease. They took one little like, nickel-sized piece of peritoneum out, and but she felt as bad, if not worse, 6 months later. And I went in there and I took out 12 implants. And they were clear, yellow, vesicular, like whatever, but it was all endo. But
Yeah.
they had tunnel vision. That you go in
Yeah.
there and you're looking for what you want to see, and that's all that you're interested in. And if you don't see that, and I think this is not that I'm doing a promo for Intuitive, but I think that the high definition 3D imaging makes a huge difference because I put my ports in using a regular laparoscope, so I see
Hmm.
what it looks like with a regular 2D camera, and then I put the 3D camera in,
It's so
and
clear. Yeah.
oh, it's like everything looks more. The resolution is much better, but you see things that you didn't see with a 2D camera.
Yeah.
So you really need to know what you're looking for, where you're looking, and that only comes with experience, and
Yeah.
that's why it's critical to
I
have an
agree with you 100%. You have to be able to identify it first to know you need to remove
right.
it and then feel comfortable doing so. Yeah.
Exactly.
Excellent. Well, as we wind down tonight, meanwhile, those in the Q&A, I'll stay on after we're done and try to take a stab at those. So, but those, let's talk. Dr. Haverland, you're coming to the Endo Summit. Feel
I'm
like we can't
coming.
have it without you. You're going to talk about some of these chronic conditions and when to do surgery and when not to do surgery, right?
Yep, that I can't wait. I'm excited to be there. It's the conference I give priority to. So I'm taking even a surgery day off.
Oh,
I
cool.
just I can't wait. I'm looking forward to it.
Excellent. And Dr. Orbuch will be heading a panel on, is it IBS? Is it nerve? Or is it endometriosis? And preceding your panel will be a discussion from Iris Wang of Mayo on the enteric nervous system and what the enteric nervous system is. And then we're going to have a big discussion with everybody because getting to the bottom of bowel pain is not easy, right?
Yeah.
Absolutely.
Yeah,
So
this is going to be great. I'm looking you have some new topics this year.
we hope. We hope every day. I feel like this is the year, and also, like I have my own issues, but this is the year we get phone calls like I'm not coming. I've gotten more than one phone call. One of the instructors had an hour-long presentation. I am very much looking forward to, which would have been an adjunct here, but she was too busy to come. Dr. Spencer is returning. She focuses on the vascular and the veins, and she's going to talk specifically about how the veins affect bladder-related pain, which I've never heard that talk. I'm very excited.
Okay.
Yeah.
Separate from like pelvic congestion.
Yes, but it's a
I guess
specific
it's
link.
similar. It has to be
Yeah.
similar to
Got to
some
be linked
degree.
to that. Yeah.
Specific
Yeah.
link from pelvic congestion to
Mhm.
she actually I think is going to make the argument she doesn't believe in IC that it's all coming from pelvic congestion. It should be very interesting.
Yeah,
Yeah.
well, I look forward to it.
Yes. All
Excellent.
right. So you can see both Dr. Haverland and Dr. Laurence Orbuch at the Endometriosis Summit. You can get tickets for either in person in Orlando, Florida, or virtually March 27th through the 29th at www.theendometriosissummit.com. I'm gonna just so Dr. Haverland, can you tell everybody how they could reach you?
Yes. So I am in Dallas, Texas with Endometriosis Center of Excellence, endoexcellencecenter.com, or my phone number is on there, 214-280-4460. I currently have an office in Plano and in Dallas. Soon that will just be a Dallas office. I'm becoming permanent.
Yeah.
Um,
Excellent.
but
And
we also do virtual visits.
excellent. And Dr. Orbuch, how can people reach you?
Sure. So my practice is at Endometriosis Center in Los Angeles. My office number is 310-980-3355. You can also look at my Instagram page. It's at Dr. Larry Orbuch, DrLarryorbuch, or my website, which is, I think, lagyndoc.com. And we're here and eager to take care of you.
Dr. Orbuch is OG Endo Summit. He's been at all the, I think one you missed, but
Maybe.
all the rest.
I'm
Yeah.
bringing in the new blood.
Your new blood. But he not only he's been at all of them from when we really didn't know what we were doing. So we always love having you guys. And I'll see you in March.
Okay,
I'll be in touch about the summit.
Bye,
Don't worry.
everybody.
Good
thank you,
night.
Sally. Bye, Larry. Good to see you
Bye.
guys.
Same here.
All right.